All right, this is an update on the system VTE at Houston Methodist to be delivered on August 27th this year. So with our VTE program, there are three main components: intervention, detection, and clinic. We're going to go through each of these and how they all relate to the VTE program as a whole. And then more importantly, probably how they are all interconnected and where the improvements have been. From an intervention arm, probably the one that gets the most press. Right now, we have a variety of different groups throughout our system that are helping take care of our patients. Up in the Woodlands, we have vascular surgery, same at Baytown. In Clear Lake, vascular surgery and interventional cardiology are starting to get involved. HMH is largely driven by vascular surgery. Sugar Land has both vascular surgery as well as cardiothoracic surgery getting involved. At West, we have vascular surgery and interventional cardiology getting into the game. And then at Willowbrook, interventional cardiology kind of leads the charge there. And then with our new facility out in Cypress, vascular surgery is going to, at least initially, going to be heavily involved. And really the take-home point from this is intervention is up across the system. We have advanced intervention available now system-wide. It is rising slowly but surely in some places, and then radically changing how things are offered at some of our campuses. One of the big things for us for intervention is how do we make this better, right? One of the big improvement strategies is how do we teach people how to do these, and how do we get people on the same page? One of the big things is with YouTube videos, how to do these things, how to treat these patients, kind of the details and how these patients are managed. And you can see down on that bottom left-hand corner of the screen, there's a considerable number of cases that we have recorded, some very simple, some very complex. And the hope is to get a whole bunch of these videos out for instructive and educational purposes. Really trying to divide these out into different groups. Some larger videos, kind of 30 minutes to even an hour, detailed manuals, just nitty-gritty detail on how to do a lot of this. Kind of 10-minute, 10-step guides, that meat and potato kind of resident med student level guide for how is this pathology taken care of. And then really kind of shorter look what we can do now videos. So highlighting parts of the program, little tiny bits of the procedures that need to be highlighted and gone into detail, but maybe doesn't deserve a large video by itself. But really trying to get access to eyes so that we can raise the level of care throughout the system. The intervention obviously leads to a significant connection to the clinic as well as the rest of the VTE system. The VTE clinic, this is one of the focal points, obviously, of our system. And coming from the intervention arm, it's a great place for post-op follow-up, right? These patients have to be seen somewhere, and this gives a guaranteed follow-up location for these patients. Really important because these are patients that need surveillance. We need to do risk factor analysis, and then we need to figure out which patients need to be triaged to both hematology and pulmonary services. But not everybody necessarily needs to, and having a dedicated clinic for this really amplifies our ability to take care of these patients and make sure they don't bounce back. Really, really important. Probably about 30% of these patients do end eventually come back statistically for future VTE. And so our hope is that by having a dedicated resource for these patients, we can prevent admissions and really improve compliance and follow-up. But the clinic's not just for this, right? One of the big highlights is for ER follow-up. There's a lot of patients that show up in the emergency room with either swollen legs, pain in their legs, chest pain, shortness of breath, syncope, things like that, but don't need to necessarily be admitted to the hospital. They're patients that with smaller blood clots that can be managed very effectively as an outpatient. But one of the big concerns in our emergency rooms is patients bouncing back, right? Not having quick primary care follow-up or specialist follow-up. So having a dedicated VTE clinic allows for these patients allows for our ER doctors to know that the patients will have a dedicated place for them to follow up within a couple of days of them being discharged from the ER. Greatly increases the chances of them getting onto blood thinners efficiently and quickly, and making sure that they have the appropriate surveillance for whatever risk factors might be leading them to having VTE. Another big point of our clinic, IVC filter surveillance. We track every single filter that we place in the hospital, and this really allows for us to do good surveillance and really get a lot of these filters out. We very routinely get our IVC filters out of people that we can get them out of, and it's kind of a point of pride of this type of clinic, because notoriously, historically, we've had difficulty getting these filters out of people. Another big one, Coumadin management. Was recently at a primary care clinic where one of the 4 doctors felt comfortable managing Coumadin. And this is a skill that is being lost because we just don't use it as much as we used to. So really, really important. Coumadin is an incredibly valuable part of the management of VTE, even in the modern era, primarily for patients that cannot afford or have difficulty acquiring Eliquis and Xarelto. Coumadin is really a pretty good place for caring for these patients, and having that resource available to our system as a whole really adds a tremendous amount of value to our primary care doctors, to our cardiologists, as well as our hematologists. And then the biggest probably advantage to having this outpatient clinic is outpatient screening, really avoiding patients going to the inpatient setting entirely. And so this is kind of its own little bucket, right? So this is what it looks like. Messages that come through Epic directly for direct communication between different clinics and the VTE clinic. This is obviously too small to really look at, but the main point is that within 40 minutes of a patient being referred over, there's already a response to that orthopedic clinic in this case, telling them that there is indeed a DVT as they suspected and what the management will be. And the patient is seen immediately. So from a patient experience standpoint, I don't think you can really get better than this, because they have an answer within an hour of them identifying that they may have a blood clot. And this is a huge benefit for our referring physicians, because this patient leaves their clinic immediately, right? And they know that they're going to get the absolute highest care possible, and that there's going to be a home for this pathology. Really, really important. Obviously, we track all of these patients that come through our clinic, both in terms of the patient numbers as well as the finances surrounding that. And then really, really important things that are a little harder to tabulate, but how many patients avoid the emergency room or avoid admission to the hospital? This is slightly outdated. This is about 6 months old at this point. But really important, a large number of patients that avoid admission to the hospital or avoid coming to the emergency room entirely. And again, from a patient experience standpoint, this is obviously wonderful, but also from an operational side, from the inpatient wards, tremendous advantage for reducing length of stay for this pathology and overall admissions. So big system benefits. We've virtually eliminated all orthopedic post-op ER visits and admissions for venous thromboembolism. We've had a couple of pulmonary emboli that really did need to be in the inpatient setting, but by and large, these patients can be taken care of very effectively as an outpatient. This was highlighted at a recent DNV survey here, where it was a notable point of pride that we can manage most of this very efficiently between the outpatient clinics, rather than using either inpatient or imaging or our emergency rooms for these patients. So again, streamlining for our primary care doctors, our OBs and ortho. We've recently had some patients that probably should have gotten screened from some of our other clinics. And so that's a big rollout part for us, is connecting with our other subspecialty clinics to hopefully reduce the number of patients going to the inpatient wards from there. And then selfishly, as an interventionalist, early identification of large DVTs, right? It's great to hear about this as an interventionalist at 8, 10, 11 in the morning, rather than the typical phone call at 7 p.m. Because the patient has finally made their way through the system, and now the interventionalist gets called. And it allows for same day or next day intervention. And this can be done as an outpatient or directly admitting the patient to the hospital, but overall it's much more efficient and effective use of resources. So increasing, again, the number of interventions that we're doing. And again, highlighting the fact that the clinic really does aid in not only the intervention side, but also the detection of these patients with the outpatient screening. So we talked about from a detection standpoint, you have ER evaluation of patients that come in with pulmonary emboli or with signs of DVT. You have outpatient screening in the VTE clinic. But one of the other big points for the detection, and really how this is going to end up going system-wide, is how we're going to kind of really change how we look at CT scans in our ERs, our urgent care centers, and in imaging facilities outside of our institution. And so this is what it typically looks like at most of our hospitals and most hospitals across the country, to be honest with you. Most patients come into the emergency room with a symptom that they're complaining of that is suspicious for pulmonary embolism, whether it be shortness of breath, chest pain, or syncope. And then they get divided into kind of three different major categories, right? Tiny or incidentally found pulmonary emboli, symptomatic pulmonary emboli without really kind of scary features, or big and scary PEs. And I use these terms a little facetiously, but that's kind of how they're thought of in a lot of hospitals these days. So those tiny and incidental PEs, either nothing happens and the patient says, well, that's not either why I originally came in here. I came in for this rash and I told you I was a little short of breath, and so you scanned my chest and you found this thing. And a lot of these patients get lost. We tell them to go follow up with your primary care doctor or maybe a specialist, and then patients have trouble getting in, or they don't get adequately anticoagulated, or their pharmacy doesn't have the NOAC that they were prescribed. And there's a significant amount of recurrence from these patients. A lot of incidental findings that just don't get followed up on. And we know that about 30% of these patients do end up recurring and coming back, and sometimes with much bigger clots than they originally came in with. For that group of patients that were symptomatic, so pretty good amount of shortness of breath or something else, but no hemodynamic changes or no tachycardia, or really nothing that gets people too excited, a lot of these patients still get admitted for anticoagulation, despite the fact that we know that we can really adequately manage most of these patients if they've been effectively managed with anticoagulation in the ER setting. That they can be managed as an outpatient, at least in unnecessary medical admission. And then a lot of times these patients will sometimes tell us that they sat in a hospital, another facility, for sometimes 3 or 4 days, and ultimately then discharged, which could have easily been done as an outpatient. And then the last one is the big and scary PEs, so the patients that people get really worried about, so hemodynamic changes or changes in vital signs, typically tachycardia. A lot of these patients get admitted to ICU for anticoagulation, and then we watch them for 3 or 4 days. In the modern times, now more and more interventions are being offered system-wide and countrywide. And so there's inconsistent care and a pretty long length of stay across the country when compared to kind of the higher volume centers that really take care of these really well. What we're really going for, though, is AI-assisted PE diagnosis. And the AI component is really a small part of this, but it's really software-assisted pulmonary embolism diagnosis, leading to a virtual PE team very similar to a stroke team. And then that team being able to triage patients to either VTE clinic, directly discharging them from the emergency room, admitting them for something else that might be going on, but then allowing the VTE team to then immediately see them and manage their care, or admit them directly to the hospital for potentially intervention. One of the big advantages of having the VTE team involved from the get-go in all of these clots, really being able to get these patients out of the hospital directly from an emergency room and knowing that they're going to be followed up on very carefully, and decreasing that bounce back to the emergency rooms. And then being admitted for other diagnoses, right? A lot of times we find VTE when we're looking for something else or when other things are going on and patients still need to be admitted to the hospital. Unfortunately, often that's because of something that would preclude them from getting their standard anticoagulation. It is very nice to have the VTE team involved early on because filters can be placed efficiently, but then also tracked. This allows for kind of reduced risk of delaying care for whether it's orthopedic injury or intra-abdominal surgery or whatever it is that requires that filter to be placed to safely manage the patient as an inpatient. And then for patients that have larger clots, really decreases the time to procedure for our interventions because the notification happens so much faster. The big reason for having an enhanced pathway for this really decrease the recurrence of VTE throughout our system, decrease the triage time, right? This really takes a pretty significant burden off of our ER teams because there's a team that's dedicated to taking care of this. As soon as that diagnosis is made on CT scan, the team can get involved, whether it's small, medium, or large, and that patient can very efficiently be moved out of the emergency room, either into the hospital or home safely. Really trying to aim to reduce our number of medical admissions for these that are unnecessary, and then decrease the length of stay of patients that do ultimately require inpatient admission for either their DVT-PE or for other pathologies. So what is AI-assisted PE diagnosis or software-assisted PE diagnosis? There's a whole bunch of companies out there right now. We are currently evaluating several of them. But really the goal is to be able to provide this just like you would with a stroke, virtual stroke service, be able to provide that first pass for our frontline providers in the ERs and urgent care centers, and imaging facilities for that matter, to be able to effectively get information to the people that need to make decisions, right? These software collate a lot of information, whether it's the vital signs or the lab work, along with the imaging. So it's all in one place. So there's no kind of fishing around for information. It's all at your fingertips in one location. And then decisions can be made. And then there's a communication function to this. I don't know if we'll end up using that. But that will then allow us to then directly communicate with the relevant interventionalists at the different facilities to get them on board if necessary, and hopefully decrease the number of phone calls that interventionalists get, where you're really only getting bugged as an interventionalist when there's something that much more likely than not needs evaluation for intervention. The big things, again, it's a platform for communicating and collating information. There's an argument that it might increase the number of incidental PEs that we find. I don't think that that's been borne out necessarily. Where we're at right now, we currently have the funding allocated for Cyprus. We really do want to obviously go system-wide, but that's going to take some doing. We're currently working on that model up here in the Woodlands of what that would look like. Dealing with a lot of IT and innovation things, like with any new system. Everybody needs to make sure that, number one, we're all above board, and that all the pieces fit together. We really are hoping to go system-wide with this and help our interventionalists to identify patients that would potentially benefit from those interventions, but then also more substantially work with those patients that don't need intervention to efficiently either get them through their hospitalization or out of the hospital and reduce our medical admissions for these patients. So with that, I would be happy to take any questions.